Dr. Shanmugam, for the nice introduction. It's not so actually. Okay, I thank Professor Dr. Mohan sir and the team for giving me this opportunity. The topic that I'm going to deal is common disease modifying OADs. The breaking new grounds in diabetes management with disease modifying OAD. The previous lectures probably has made me to sober down a lot because they have already narrated everything. I'm just going to be a chittoru patch of work. Disease modifying all the things Dr. Vijayakumar, the indication Dr. Srini, everybody has clearly narrated the OHAs, which are the background of the disease modifying OADs. So the diverse metabolic disturbances in type 2 diabetes coupled with the associated micro and macrovascular complications are collectively called as the cardiorenal metabolic disease in type 2, as Dr. Vijayakumar has properly told. And the glucose lowering agents that have got a cardiovascular protection, that has got a beneficial effect on heart failure and the renal and liver protective mechanisms, and they are called as the disease modifying agents, well proven by the all the multinational clinical drug trials. Of course, the GLP-1 receptor agonist and SGLT inhibitors and metformin and glitazones, these four drugs forms the basics of this disease modifying drugs apart from the other things. These are the four major drugs that comes into the category at present as a disease modifying agents. Early research into the extra glycemic effects of the various drug trials, UKPDs are called advanced trials, all they have said that effective at reducing the microvascular complications. They have shown the results on the reduction of the microvascular complications, but not much of benefit on the macrovascular complications. So only intensive glucose control approach is not enough for cardiorenal metabolic benefits, as you know pretty well. All these trials, ACCORD and VADT, also have done the same thing. They proved the beneficial effect on micro, not on the macrovascular complications. We know the rising burden of the cardiometabolic diseases, so many things, hypertension, diabetes, dyslipidemia, obesity, all contributing these cardiometabolic diseases, and so many metabolic risk factors also are behind it, and this contributes a lot of burden for treating in type 2 diabetes, not only to bring down the glycemic parameters, but also the complications, all the micro and macrovascular complications. So we need to concentrate not only on reduction of the microvascular complications, also we have to focus on the macrovascular complications, where these disease modifying agents helps a lot in bringing down these macro complications. So this is the paradigm shift that we noticed from 2000. The glucose lowering agents, they improved only HbA1c, and after that we were seeing only on the hyperglycemia and weight gain aspects, and after that in 2015 onwards we started looking into the cardiorenal and metabolic complications, and of course way behind 2020 only we have now classified the disease drugs as a disease modifying drugs, where it improves not only HbA1c but also the basic parameters that affects the cardiorenal metabolic factors. And expert Professor DiFranco also has enumerated these four drugs, SGLT2 inhibitors, GLP-1 receptor agonists, pioglitazone, metformin, as a cardiorenal metabolic drugs that focuses on the disease modifying action. So first I'm going to focus on the pioglitazone, the forgotten molecule for a very long time. The emerging role of thiazolidinediones. They are the deputies to the regulation of the transcription of genes that involved in the glucogenesis and the lipid transport and fatty oxidation, and more so the epigenetic modifications. They represent the nuclear receptor expressed throughout the body, at the liver, skeletal muscles, heart, kidney, and adipose tissue, especially on the adipose tissue. And at the level of mitochondria also, there is a decreased pyruvate entry, and thereby the mTOR pathways activation is inhibited, and that produces a lot of metabolic and inflammatory, and the proliferative pathways are taken care of it. So this is the forgotten cost-effective cardioprotective drug for type 2 diabetes. No, this improves the insulin resistance syndromes, various aspects of the IRS, and the plasma glucose, blood pressure, on the lipid, all the lipid fractions except the HDL, and it shifts the fat from the visceral adiposity to the peripheral, and thereby it ameliorates the lipotoxicity, takes care of the MASLD and NASH also, and of course especially the plaque formation and the plaque inflammation, one of the main aspects of the cardiovascular event, that also is taken care of this by the pioglitazone molecule. As Dr. Sheshatri, as previous lectures have told, pioglitazone seems to be the poor man's GLP. Yes, it seems to be a poor man's GLP. So now we started rethinking about the pioglitazone. No, the main concern on pioglitazone we have seen so far is a weight gain, bladder cancer, decreased bone mineral density, fractures, and the fluid retentions. All these things are hindering us from writing these products. And especially after the rosiglitazone scenario, we started neglecting this molecule a lot. But a lot of things happened with this pioglitazone molecule. And despite the increased risk of hospitalization of the heart failure due to fluid retention on the pioglitazone usage, what they have inferred is there is associated with the reduced risk of myocardial infarction and ischemic stroke, especially on the CNS system. There is a ischemic reduction of the ischemic stroke seen in both primary as well as the secondary prevention without any proven direct harm on the myocardium. So they have got a very good cardiovascular improvement without any harm to the myocardium. So pioglitazone has got an edge over the other drugs in all these things. So after the trials on SGLT2 inhibitors and the GLP-1 receptor agonists, there is a Copernican revolution that happened on pioglitazone, and they are now bringing out the molecule in a better way, that the usage of this molecule should be extensive by all the practitioners nowadays, thinking into and having in mind on all the beneficial effects that we are going to tell in the next 2-3 slides. This slide was repetitive actually. It has got a beautiful action on the heart musculature. It increases the myocardial perfusion. It has got a action on the left ventricle function also. Cardiac remodeling also, it reduces the preload and afterloader, and you can got the action on the electrophysiology also, on the atrial fibrillation. It has got a beautiful action, the increase the sinus rhythms also is seen, and there is a decrease in the 30% of the atrial fibrillation that has with this molecule. That is only thing, it has got no action on the pulmonary vasculature at present. There is no studies that has been contributing to the pulmonary vasculature. Otherwise, all the vasculature system, pioglitazone scores over well. And these are the pleiotropic effect which we have seen. The previous speakers also shown about the adipose tissue action and muscles, pancreatic systems, everything. It has got not only the reduction of the glycemic parameters, but also the inflammatory pathways that are involved. And especially you can see the pioglitazone has got action on the hypothalamus, and that causes the augmentation of the appetite also. And number 2, it acts on the adipocyte and increases the adipogenesis. And because of the newly formed fat cells due to the adipogenesis, these fat cells absorb the free fatty acids from the circulation, and thus it reduces the free fatty acids in the circulation, and also it reduces the deposition of the free fatty acids on the liver and musculature happens. So this is one of the main actions of the pioglitazone molecule with respect to the adipose tissue, and that's one of the cause of the weight gain, and of course it has got a contribution to the major beneficial effect on the cardiovascular system. And this is a disease modifying action of the pioglitazone on the vascular system also. So you can see the coronary artery atherosclerotic process are much lessened, and the blood lipid parameters are well taken care of by this molecule, and arterial stiffness especially. The receptors of the pioglitazones are more in the smooth muscles of the vasculature. Thereby the action on the arterial system also is very much pronounced with the pioglitazone molecule. Of course, these two major trials, Periscope or Proactive study, Chicago study, and IRIS, all these studies on pioglitazone are well proven that pioglitazone resulted in a significant lower of the progression of coronary atherosclerosis in the Periscope study. And if you see the Proactive study, there is a 16% reduction in the MACE events, and even Chicago study, it has got a huge reduction of the carotid indward thickening, and in IRIS study, 24% risk reduction in the occurrence of the fatal and non-fatal myocardial infarction. So much of beneficial effect they are shown with all these 4 major trials on pioglitazone. Of course, the pioglitazone is equally effective for diabetes prevention in older versus younger adults with impaired glucose tolerance. So this is a study they have conducted with the older people and younger people selected with impaired glucose tolerance test, wherein this study has shown, ACT now trial shown, diabetes incidence reduced by 85% in the older adults and 69% in the younger adults, and improved beta cell function 35% in the older and 26% in the younger adult group, And of course, increased insulin sensitivity also seen and adiponectin levels also in both the groups. So all the beneficial effects both in the younger and the older groups are seen, and reversal of diabetes also is possible for the pioglitazone molecule that is well shown in the ACT Now trial. Of course, the next molecule, SGLT2 inhibitors, Dr. Vijayakumar has clearly enumerated nicely, and I think I did not go for this. Again, the disease modifying action of the SGLT2 inhibitors on the several organs and functions. Of course, this is the disease modifying action of the SGLT2, where it has shown a tremendous effect on the kidney and the heart and the blood vessels. You can see the effect on the natriuresis and metabolic efficiency, increased oxygen supply also, and you can see the decreased fibrosis in the myocardial system, and decreased epicardial fat accumulation, and increased endothelial function. Arterial wall stiffness is much reduced with this molecule. So much of action that contributes to the decrease in the cardiac preload and the cardiac afterload also, contributing to the cardiac remodeling that produces the increased left ventricular diastolic function and decreased left ventricular mass also. And this is one of the things that we want to highlight it. This is the role of inflammation. This is the inflammation is that's one of the marker of the system that is present whenever there is an acute myocardial infarction that happens. And this inflammatory pathway that involves the NLRP that triggers the interleukin system, interleukin and the PNF, TNF alpha, and that contributes to all the cardiac mortality rate. And this SGLT2 preferably inhibits this NLRP3, and thereby the production of interleukins and the TNF are much reduced, that produces the beneficial effect of the cardiac remodeling when the patient has gotten acute myocardial infarction. So any patients on SGLT2 inhibitors sustain an acute myocardial infarction, the revival rate is very fine with them, because that molecule SGLT2 inhibitors that prevents the NLRP inhibition, thereby the cytokines release are much reduced. So this is one of the important pathway that takes care in the reducing the inflammation in myocardial. And of course, the next one is the SGLT2 inhibitors, the role in the protective programming of the cardiac nutrient transport metabolism also. So you can see the failing heart, you can see nutrient transport into the myocytes is increased, but nutrient utilization is impaired. This is the main thing that we have to note it. The transport to this is increased, but only the utilization is not proper, it's impaired. And thereby it produces two types of events. One is the accumulation of the deleterious glucose and the lipid byproducts, and also the deficiency in the ATP production. These are the two major events that happens with it. So these byproducts trigger the downregulation of the cytoprotective nutrient deprivation pathway, and SGLT2 inhibitors takes care of these two pathways and restore the cellular homeostasis by directly binding to the nutrient deprivation and nutrient surplus sensors to promote their cytoprotective actions. And of course increases even the ATP synthesis also. So thereby the SGLT2 inhibitors action on the protective reprogramming cardiac nutrient transport system is much enhanced, so that the cardiac outcome is very good with the molecule. Of course, you know the legacy effect when we start the newly detected patient on SGLT2 inhibitors, the legacy effect also is properly maintained. Well, the only thing is we can combine these two molecules, SGLT2 inhibitors with pioglitazone. Why we can combine this molecule? First reason, you can see the fluid retention is more common with the pioglitazone, and body weight increase also with the pioglitazone seen. But these two effects are nullified by the SGLT2 because SGLT2 inhibitors have got a decrease in the fluid retention and the decrease in the body weight. So both the actions are nullified, and Professor D. Franco puts his perspective on the possible fluid retention and weight gain mitigation effect of the SGLT2 inhibitors and pioglitazone combination. So these two molecules combination is one of the wonderful combination that we can easily prescribe the patient due to various reasons. So the empiric study showed that empagliflozin is significantly decreased the MACE endpoints in patients with high risk of type 2 diabetes, primarily through a reduction in the cardiovascular death without a significant decrease in either myocardial infarction or stroke. So the cardiovascular death is reduced, but not much of improvement in the myocardial infarction and stroke in empiric outcome study. If you see the proactive study of pioglitazone, it has got a reduction in both recurrent MI and stroke. with a modest reduction in the cardiovascular death. So these two actions which are not present with the EMPA are nullified by the pioglitazone, which action is not there with the empagliflozin is compromised by the pioglitazone molecule. So for these two reasons, to decrease the cardiovascular death and to have a better outcome of the myocardial infarction or the stroke events, if we combine these two molecules, this can be easily prevented. So pioglitazone might be an ideal agent to combine with empagliflozin to further reduce the cardiovascular events in patients with the high risk diabetes. Of course, this combination therapy has been proved by this study. It's a real world evidence from a nationwide cohort study has done. They have shown that the decreased MACE risk by 25% and myocardial infarction risk by 19% and stroke by 28% and cardiovascular death by 11% on heart failure by 33%. Of course, next come the GLP-1 receptor agonist oral formulation as a disease modifying drugs. You know, various actions of the GLP-1 receptors on the brain and the gut and the heart and the kidney, various actions on the adipose tissue muscles have been enumerated properly in the previous lectures, and the HbA1c reduction with the different GLP-1 receptor agonists also shown modest decrease in the HbA1c reduction seen in all the trials, and of course all the endpoints in the pioneer program of semaglutide molecule have confirmed the primary endpoints, and confirmatory secondary endpoints are very much better in pioneer 1 to 5 and 7 and 8. With respect to the change in the HbA1c level, with respect to the change in the body weight also. Of course, Pioneer 6 cardiovascular trial that the MACE events are first the primary endpoints were much prevented, and the time to occurrence the expected composite endpoints also was better with the Pioneer 6 programs. And of course, the oral semaglutide results from the CV outcome trials with all the Pioneer 6 programs overall summary also we have shown the oral semaglutide achieved its primary endpoint of MACE reduction versus the placebo with a 21% non-significant risk reduction was seen. So this semaglutide molecule, oral semaglutide in GLP-1 has got all the benefits on the cardiovascular system, which can be denoted as a disease modifying agents. Here I am just mentioning only the semaglutide molecule oral because the topic given to me is a disease modifying OAD combination. So I am not going to the detail of the injectable GLP-1s, GLP analogs. Of course, the weight loss also across all the combination therapy has shown drastically that there's a good amount of weight reduction if you combine this GLP with all the other drugs like empagliflozin, sitagliptin, liraglutide molecules also compared with insulin also they compared it. And of course, in MASH also you can see that there are so many actions of the molecules have come out to deal the MASH. You can see the 4 events that occur in the MASH events. One is the steatosis, that is the factor accumulation due to the insulin resistance that causes the inflammation and the liver fibrosis. And in all these categories, you can see the GLP-1 receptor agonist and the SGLT2 inhibitors and pioglitazone are taking care of it. So these 3 molecules takes care of this insulin resistance and steatosis and inflammation. Of course, the liver fibrosis probably among all these 3 drugs, seraglitazone also has got a role in this. So pioglitazone, GLP-1 receptor agonist and SGLT2 inhibitors in the treatment of type 2 diabetes with MASH and MASLD also is much encouraged here out. Of course, metformin, Dr. Unikishan has clearly showed. I am not going to the detail of metformin because it's a time constraint. So it provides cardiovascular benefits. Metabolic parameters are also improved. Reduces the insulin resistance, central mechanism of MSLD. All these things are there with the metformin therapy. It has demonstrated the biochemical improvements also in the liver enzymes and reduce the risk of hepatocellular carcinoma. And metformin remains the backbone of diabetes management, and it should be complemented with the agents that specifically address the MASLD progression. Of course, this is one of the methods, simple approach, the choice of medication, how you are going to choose. You can see that most of the patients with the lifestyle modification, metformin and the disease modifying drugs or diabetes modifying drugs, we can say. So what we can do is first and second line of therapy for most patients next to the metformin, what you are going to choose. If the patient has got a risk of for the heart failure and CKD or the ASCVD, probably metformin and SGLT2 combination can be preferred. and the patient has got a risk for a ASCVD, metformin and GLP-1 receptors agonists can be preferred. And of course, along all these things, if the patient has got a obesity, the SGLT2 inhibitors with the GLP-1 receptors will be a better choice. So this is the combination that you can choose. This is according to the simple approach by which we can choose the drug according to the category of the patient. So the triad cardiorenal, brain and liver abnormalities can be addressed with a combination of these disease modifying drugs of the pioglitazone, SGLT inhibitors and the GLP-1 receptor agonist. So the risk of stroke or transient ischemic attack or the development of and progression of MASLD or the cardiorenal diseases, MACE reduction, CKD production, all these things probably, these the three drugs, disease modifying drugs can be a preferred choice to treat not only for the control of the sugar level but also to alleviate all the cardiovascular complications, cardiorenal metabolic complications of the patients. Thank you.